Okay, it's great to be here. We're here to talk about canaloplasty, and I am incredibly happy to be in the company of two greats, George and Rachel. I mean, amazing surgeons and amazing people as they are. And this is actually the best thing that happened in the whole meeting. Rocking Crocs, just so much nicer than the heels. Well, you don't have that problem.
I left my heels at home, so.
So let's get started.
Yeah, let's get started. We're going to talk about iTrack Advanced today, and we're so glad that you guys could all be here to join us for this discussion. Of course, we have some slides, but really what we want this to be is an interactive discussion. So please feel free to pipe in with questions, comments, if you want to tell us how you're incorporating this into your practice. Really, this is supposed to be a discussion that we're just up here facilitating and all of us are participating in.
Exactly, so just raise your hand and we'll call on you. We'll repeat the question and do our best to answer it, okay?
Absolutely.
I mean, I know that we have a mix of some people that canalize tear ducts, some people that are glaucoma. The question is, how many of you believe in mix? I think that now with all of the CMS situation, the first thing is, are we believers? Do we really believe that mix is the way to go? Would you have a mix or would you end up having a trap? Would you like a little extra before you get to that point? And I think it's very important to know that as glaucoma specialists, we do believe that this space and having this option is important. And then as you go through all of the mix, why is canaloplasty different? And why is iTrack with pressurized viscodilation different than the rest?
Yeah, and Analisa, that's a great point because we know that all our patients are different. We have to take every patient as an individual. Not all glaucoma is the same, not all patients are the same, and we need to have different options to treat our different patients. And it is a challenge now that we're going to have less options in the future, but it's really up to us and the patient to decide what's best for that patient, and we make that decision. So really, it's important to keep that in mind. We're not just treating pressures, eyeballs, fields, we're treating people. We're treating people.
And I think the third thing that always comes in with any discussion of MIGS is what are our measures of success? Mm-hmm. And that is a conversation that I'm really intentional about having with my patients when we talk about MIGS is what are we hoping to get out of this? And is this going to cure your glaucoma, or are we going to be able to maybe get you off an eye drop? How are we going to improve your quality of life? And those kind of expectations really help them understand where the role of MIGS fits into their treatment of what is a chronic disease.
Right, and of course, we want to prevent blindness, of course, but it's more than treating the pressure. It's about, like you said, quality of life. And that's where MIGS shines. When we reduce medication burden, make it easier for our patients to treat their glaucoma, we're ultimately improving their quality of life. And that's where interventional glaucoma is focused. Right?
I am curious, before we get started, just one question for everyone here. Who right now is using the new iTrack Advance currently? Is anybody using it right now?
Nobody's using it.
Okay. Is anyone using the traditional iTrack? Okay.
Okay.
All right.
You're in for a treat. I think there's a few things that make it different, and we're going to be pointing it out as we go.
And then, is anybody doing another form of canaloplasty other than iTrack?
Yeah.
Okay. All right. Excellent.
In some of the other countries, they don't have access, but they had GAT that actually could go 360, and you would, go through the canal even if you're not viscodilation.
All right. Well, let's get started with our slides then. Let's see if I got.
Does it work?
There we go. Got it. We're good.
Well, as we go through it, so let's get a little background on this. You have a canal that is not necessarily distended. You have a canal that is virtual, that is collapsed. And you have this canal that as glaucoma progresses is going to start getting stiff. So when we go through anatomy, I think you have to keep that in the back of your head. This canal goes through collector channels and then goes to the episcleral venous system. So as we go through this, you're going to have to think of this as a system. And when you have a system, you have to try to incorporate treatment for as much of it as you can. And with this device, you're able to kind of target multiple locations of the aqueous drainage system. So
And one thing I think we can all agree, a benefit of MIGS is that we're utilizing the natural anatomy of the eye. So that is kind of one of the original advantages of MIGS, and remains one of the advantages of MIGS, is that we are augmenting the natural outflow pathway of fluid. And anytime we can make that work better, the patient is always going to be in a better place than if we are bypassing the natural anatomy.
Right. And so it's important to remember that what we see in the eye as the trabecular meshwork is the drain of the eye. It's really the tip of the iceberg, right? Because beyond the trabecular meshwork is Schlemm's canal, and as Analisa mentioned, that collapses when the pressure goes up. Everything downstream, the collector channels, the episcleral venous system, that tends to atrophy. And so iTrack enables us to rejuvenate the natural collector, the natural drainage system of the eye. So it doesn't just work at one level, it works at multiple levels downstream, and it's very unique in that way compared to other MIGS.
We know glaucoma is an outflow pathology. The pathology is in the outflow. And we also know it's not just at one place in the outflow system. We know it exists in multiple places along that system.
Right, and so this slide shows 75% of the resistance is at the trabecular meshwork, but you got 50% of the outflow facility in Schlemm's canal and an additional maybe 90% in the collector channels. So it's not, like I said, it's the tip of the iceberg in the meshwork. It's everything downstream that's just as important.
Right, so just sometimes simply removing trabecular meshwork is not going to get all of these other aspects of obstructions to flow.
So what does iTrack entail? So first of all, you're going to go in and you're going to canalize this canal. And that's a big difference between iTrack and some of the other devices. Once you canalize it, it's just not enough to go through it. You need to distend it. And you have all of this debris, if you want to think about it, through the collectors, through the Schlemm's canal. And I tell my patients, it's like when you have a sink that is stopped. You have to go in and you have to clean all of the debris that is in that pipe in order to get it to work. So not only you catheterize, but then you're going to viscodilate. And there's different ways of viscodilation. You can have a little bit, or you can actually put pressure on it and push all the debris out. And I think that's the biggest difference. I mean, you do most of the MIGS. I know you do most of the MIGS. And this is like the tipping point when you're thinking of which one to do. If I think that I can rejuvenate it and clean the debris and still get it to function, I've been tipping my weight scale more towards canaloplasty.
Right, and there's, we all do all the MIGS. There's so many choices. The MIG space is extremely crowded, as you know, and we even disagree or don't even know which one's best all the time, but it's important to realize it's a ring, it's a 360 ring, and there's many devices that can viscodilate Schlemm's, okay? But this is really the only one that is going to get you 360 degrees all the way around in one pass. That's what makes it really unique. And I think, when we talk about MIGS, it's minimally invasive, right? And what does that mean? It means we preserve the structure, we're not cutting anything out, we're not destroying tissue, and we're not leaving anything behind. So we leave the system as untouched but rejuvenated as possible. So it really epitomizes what MIGS is all about.
So we'll talk just real quickly about kind of the 3 steps of what canaloplasty is and why we actually think it's really effective tool in angle and in the MIGS space. So the first is just catheterization of the canal. And we know, like we just saw in the earlier slide, a lot of our resistance to outflow is right here in this canal. So one of the advantages of the iTrack is that you get 360-degree canalization of the canal, and it's very, very easy and intuitive, that 360 degrees. That catheter just slides literally like butter.
And it's two folds, I think. It's the tip of the catheter is very round, and the catheter is not very stiff.
Yes.
And by doing that, if you do encounter resistance, you're not popping through the resistance, you're able to tactile feel it and dilate it and treat it. And then the fact that I have a light. So I was a disbeliever. I'm a little skeptical on everything. I was the light is a gimmick. The light is a gimmick. And then I started doing it. And then literally I'm seeing the light go through, and instead of following the round curve of the eye, it's doing this. And I'm like, nah. So I turn off the light and I retract and I pass it again. And he's like, so I was totally inside a collector channel, and without that light, I would have never known. And what would have I done? I would have ripped open and tore the whole system when I was not even into Schlemm's canal. And I think that one patient made me a firm believer that the light is important. Knowing where you are when you're treating the 360, I think that's
the light. Yeah, I agree. The light to me makes all the difference. And I'll say again, for some other devices that do canaloplasty that seem to have a little bit stiffer of a filament that is dilating, I can't tell you how many times I'll go in and then come out and all of a sudden there'll be heme somewhere in the eye. And I'm like, well, where did that come from? Clearly somewhere this catheter came out of the trabecular meshwork.
You don't want to create another Schlemm's canal. You want to stay in the one the patient has and fix it. You don't want to create it your own. Right, and so the light really is important.
I mean, with that light, you just literally watch it go 360 degrees around the eye. It is in time, exact, real world confirmation that you are exactly where you need to be.
And a couple of you said you did traditional ABIC with the old device, and I did many. We've all done many of them. It was just a little more difficult to implement. So the idea was the same. The beauty of iTrack Advance is it takes that essential treatment modality and just makes it more user-friendly. It's more accessible to people.
I have a question. Who knows what the dolphin sign is? What happens when you're passing that canal and the filament starts going south to the ciliary body? The patient goes, and immediately you know that filament is not where it needs to be. Do you see it? I actually was very surprised with this. I rarely get the patient giving me the
I have not had, I mean,
because
I've not had it happen yet.
it's surprising. It's one of those things that you don't realize because it stays inside the Schlemm's, and it's just because of the bulb and the softness of the filament.
Well,
I think it's
the whole trick is trying to get it in the canal in the first place. That's where it really shines, right? You don't have to make a separate goniotomy. You don't have to re-grab. It's a one-step, in and out, done procedure, and that's the beauty of it.
And you know right away that you get immediate feedback right away that you are starting in the canal and then advancing through the canal, instead of what can sometimes happen where, you know, that filament starts to dive down and you're in the superciliary space.
We have some videos to show, but you know, let's keep going with the physiology.
Tell me about you're extremely bright. Tell us about the pressurized viscodilation. I think this is the biggest thing, but
I agree. You know, the idea is there are some devices where you have passive viscodilation and there are some where you have pressurized viscodilation. And essentially the idea is that you are in control of how much viscoelastic is being injected into Schlemm's canal and subsequently filtering its way down into those collector channels. And one of the most useful things I'll find is that, again, with the iTrack Advance, as I'm advancing it, when I hit those little fibrotic areas, those little bands, all it takes is a couple clicks of viscoelastic and immediately you get instant tactile feedback that amount of viscoelastic has then dilated the canal adequately enough that I can continue to pass that filament. So you know in real time that you are actually breaking adhesions and opening up that canal.
And so people, you know, and I wondered this too, like, well, I viscodilate the canal, great, but how does more aqueous get into the system? You're not leaving a stent, right? Doesn't make sense. Well, with pressurized viscodilation, you're actually creating numerous micro perforations at the level of the meshwork for 360 degrees. So you're actually improving the outflow facility, so you don't need to put in a stent.
Yeah. Yeah, so you get these little micro perforations throughout the trabecular meshwork, so you're actually improving filtration without leaving a device behind in the eye, and then allowing that into a canal that is now much more open and able to facilitate drainage of that fluid.
This video is quite impressive. So basically you take the viscoelastic, and it's quite cumbersome, but you can mix trypan blue into the viscoelastic, and then when you attach it to the iTrack device, you're gonna see this is the first generation, And as they are retracting, you can see the light, and it depends on the lighting, but I think you can see the light going through over there. As you're pulling through and injecting viscoelastic under pressure, you're seeing this backflow, how the viscoelastic trickles into the AC through the trabecular meshwork microfractures. And this is something you may not notice if you're not staining your viscoelastic, but that kind of makes sense. And sometimes you actually see the viscoelastic trickle down into the collector channels. And when you're seeing this, I mean, it's bad light, but you can actually see it in the video, all in this side, and you can see it right there in this part of the video where you can see the viscoelastic stained with trypan blue go into the collector system.
So just go back a little bit on the video if you can. It's a pre and a post. So you'll see the difference is not only in the limbal blanching, that's the viscoelastic filling the collector channels, but you also see a little bit of the trypan in the collector channel. So it's going both ways actually. You're going downstream into the collector system, but you're also going back through the trabecular meshwork into the anterior chamber. So let's just take a quick look at that. So once again, we're pulling the catheter through, and we're seeing that limbal blanching, we're seeing that backflow through the meshwork into the anterior chamber.
As a person who likes immediate gratification, I do have to say that watching the blanching is my favorite part.
See the collector channels, and post, see the limbal blanching and the trypan in the AC and also at the limbus. Okay, really a nice example by Kahemi about that. This is Paul Singh.
You always can tell when it's his video because of the traction.
Yeah. So he's just testing the catheter, making sure that the viscoelastic is going through. He's going to put his gonio lens on.
And the last one we saw was the first generation.
Yeah.
It looks like this is the actual iTrack Advance
watch
that we're seeing here.
how easy it is, okay, for Paul to make a tiny little goniotomy and get that catheter in.
Well, I wouldn't say that it's easy for Paul because it's pretty easy for anyone. I think the ease of the device is
So
quite
there it is,
remarkable.
right there. He's in size, he backs off a little bit. It's a
And you have
slider
immediate
mechanism.
confirmation with the light that it is going around in the proper anatomy.
Now, don't blink or you're going to miss it. You see that thing just flew around.
And now he's slowly withdrawing it while injecting viscoelastic.
And you'll see some blanching. I think it's right here in the video. So your scrub tech is, clicking, like 4 clicks per clock hour.
I think, did we talk already about the device itself? The way this device works is that you connect it to a whole tub of viscoelastic. And the amount of clicks that you're delivering of viscoelastic, it's something you get to control. And if there's a resistance, you will tell your assistant to give me 3 clicks. And you will click, click, click. But you have the control of telling the patient. And sometimes you will see that this is a very slow when you're retracting, because at this time you're actually giving clicks of viscoelastic. So you're counting down with your technician, 1, 2, 3, as you are removing the device. Now, it's been used forever. And I think that, the proof is in the pudding. Try a few and you're gonna see what you see. It really changed a lot of things to me. It was very easy, very intuitive. It's just a slider that comes in and out. And it just started in April. So the new device got approved in April, and I think we started it right away. You started right away. No?
Yeah, I have to say, so prior to iTrack Advance, I was probably 50-50 iTrack versus other canaloplasty devices, depending on, how long I thought my patient could hold still, and who was, was I out doing the case with a resident or a fellow, and a whole lot of other factors. How much blanching did I want to get? How much viscoelastic did I feel like I needed? And since the iTrack Advance has come to market, it is literally 100%.
It's very easy. It's
incredibly easy, And it's also incredibly safe.
We're talking, remember I told you that the catheter had a bulb at the end? I think once you see the bulb, it's very smooth. And the polymer used for the catheter itself, even though the guide wire is nitinol, it's very supple. So you're not popping through resistances, you're actually getting to dilate them.
Yeah, and we've already talked quite a bit about how titratable the viscoelastic delivery system is. It just has this very intuitive knob at the end, and you're literally in direct control. You're just say click, and you can then get immediate audio feedback from your scrub tech who's scrubbed in with you. You can hear them clicking, and you tell them click, 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 you know, I want 3 clicks, and you literally hear it 2 seconds later, they are doing it. So you know exactly how much viscoelastic is being delivered. And I know we've talked a lot about the illumination, so you always know exactly where you are.
Have you had the catheter go the wrong way? Have you seen it?
Several times with the older device. I think this device, it makes it a lot easier to line it up so you're right along the path. So I've not seen it yet.
I've never had it go the wrong way yet with the new device. A couple times with the old one where it wants to go down a collector channel, but
I will say on my very first case in Panama, I had an obstruction and we tried to click through it. We couldn't. We just went the other way. So it doesn't mean you're not going to get an obstruction, but you do have a way of trying to work through it.
Obstructions are part of the pathophysiology
Yeah, that's the
of glaucoma, so
pathophysiology.
we're expecting them. What I like is that I can feel them.
yeah.
That's one thing I didn't have before. Not being able to feel that resistance just made me pop through it. And I realized how many times I was popping the wrong way.
So we have one of your videos.
That's one of mine.
Analisa.
So I'll talk a little bit about it. So this, I think it was my first case. So you do need a separate paracentesis. So you're making a paracentesis that is directional. It's not the one that you use for your phaco. You want to direct it towards the angle. And as you're going through, I think this is my first one. I was not even embedded as I like to be in the angle. But you're going to see as I'm retracting how the viscoelastic kind of still is dilating through the canal. And you can see quite a bit of blanching. This is quite common. It's not like a surprise. And this is before you're actually doing an INA. That viscoelastic is inside those collector channels. And this is only 30 clicks. And I wanted to show the amount of viscoelastic you're pushing through. So you're getting some into the anterior chamber. You're getting the whole canal dilated. And a lot of it is going all the way down to the collector channels. You're not seeing these patients have spikes in pressures after. You're not seeing the viscoelastic is doing its purpose. It's creating those microfractures, and it's not a little amount that is just lubricating that canal for your guide wire.
So Analisa, you know, the audience can see that she did this after she did her phaco. So maybe we can comment on, is it better to do it before your phaco? Is it better to do it after?
I'm an after phaco. I mean, there's a lot of people, I know that people that train residents. So when you're doing a phaco and it's gonna take a resident 20, 30 minutes to do a phaco, that cornea is not gonna have the great visibility because there's gonna be this microedema, even though it may look clear, the minute you put that gonioprism, that reflection you get is gonna be more difficult. I think that if you're a beginner cataract surgeon or if you have a very thick cataract, that you know is gonna get some corneal edema intra-op, do it before. If you're training residents, do it before so that cornea is good, unless you're finishing up and the residents are good with phaco. I'm a before.
Rachel, what do you train residents?
I mean, we do it after.
In July?
July, maybe we do it before. I usually do it after, and for a couple reasons. We have a lot of people with like kind of narrow angles. And I actually think your anatomy and visualization is a little bit easier once that cataract has been removed. Of course, as long as you're preserving your cornea. So definitely if they have a lens that I know is going to take quite a bit of energy to break up, we'll do it before. But I usually
like
do it at the end.
I like my angle wide open. Yeah. I like the fact that, you know, I have a lot of space.
Exactly.
Yeah, I agree. I think it depends on the patient, obviously. It always depends, right? If you have a big lens, taking up a lot of space, narrow angle, for sure you should do it after. But if it's, you know, it's your typical open angle, you can do this whole thing through one incision, which makes the AC very stable. Then you can go back, you viscodilated, yes, you have maybe a little bit of blood, go back in, do your phaco incision, rhexis. So it can go either way. I think
It can go either
depends.
way. It is very much surgeon preference. There's no right or wrong way to do that. You want to go through Sahar's video too?
Well, I mean, I think the video is, I think this was one of her first cases. Sahar
But she's done it after the phaco.
She's a new converter. I mean, one of those, and I think that you see this a lot. A lot of us change after trying this. The ease of use is remarkable. But she's going in, again, a directional paracentesis. She goes right into the canal. Sometimes I do bevel my injector a little, and I do a small goniotomy just to get the catheter to go in easier.
And I will say, speaking of residents and people who are learning, I do, for my residents and fellows who are getting used to this, have them go in with an MVR blade and just make a tiny little goniotomy.
I just tilt it a little bit.
Just a little bit. Just so that you're 100% where you're starting with, and it makes things a little bit easier. And then as you get more familiar with the device, then you don't need to do that part, but it does help for the beginners.
And I think it was one of her first cases, but she's also a very good surgeon. Yes. And it's important to understand you have to back up slow. At the beginning, you just want to go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and just remove the catheter. This is, do you inject fillers like that? You could take it slow. You want to mold it. You want to get those frowning lines perfectly in place. Well, it's the same. You want this viscoelastic, and you want to give the viscoelastic time to deliver. You don't want to go way too fast.
I like
she
to
did a great job.
maximize the pain when I have my filler. No, I'm just kidding. Okay.
But you can see remarkable blanching on hers.
Really good example.
And you see it more often than with the others.
I have to say, I scrubbed with one of our comprehensive surgeons who wanted me to come do the MIGS part of his cataract surgery. So we did an iTrack Advance, and this was someone who had really inflamed eyes from being on, latanoprost and Ropressa, and he was like, what's happening right now?
Why is the
eye so white? And I was like, this is literally the best part of doing this procedure, is watching this. So now he is a believer, and I think I'm actually going to kind of teach him how to do this and build this into his there's enough glaucoma out there that he's like, I feel like I could probably add this into what I'm doing for my patients as well.
I was like, this takes too long. I don't have the attention span. The ones that know me, I'm like, I'm kind of like a hummingbird. I need to go in, come out. And going in and doing the gut. Exactly. It's like I couldn't sit there and feed this catheter as I was going through. And I do think that the new injector was what made it accessible to everyone. It's very easy to use. You're not clicking away, you don't have that downward pressure. It's an easy slide in, slide out, even for little hands like mine.
One of the deciding factors for me before was I would do a different canaloplasty procedure on someone where I didn't think they would be able to hold still for very long, specifically all my VA patients who, I don't know why, for whatever reason, cannot hold still. So I'm like, I don't want to be in the eye, that long. But this is so quick and efficient, and also safer. To me, there is no reason why this should not just be the only canaloplasty device I use.
And I think we talked about before or after cataract surgery.
This is a good one.
Yeah.
Okay, I'll let you take this one. Where are you positioning?
I think this should be your go-to MIGS. After you've done your SLT a couple times, after you maybe put a Durista in and you're looking to go to the operating room. Where are you going to start? I think you start with something that's easy to do, minimally invasive, quick recovery, all the things we love about MIGS, and it's really going to leave the system untouched. You're not going to burn any bridges.
Your anatomy is completely preserved.
It's totally preserved, not burning any bridges, right? You could even do another different MIGS if you had to.
You could go back and do another SLT a couple years.
I've done it.
Yeah,
because it's the same mechanism.
Because that anatomy is still, that trabecular meshwork is still there.
I was in an ad board, and there was a cornea, and he didn't understand why on earth we glaucoma people are always thinking of the next step. and I was like, well, the thing is that when you do a DMEC or a DSEC, you're not expecting that cornea to then compensate again. Now, I do cornea, and my DSECs will fail because they usually have a couple of tubes in the eye from before, and by definition, they have like 5-year lifespan. But for regular folks, you do something that you expect to be permanent. But for glaucoma, you're always thinking of the next. And now we're getting new technology. I think that you touch on one, extended release drug. We're having another extended release device coming up, hopefully December this year. Where are you gonna put that device if you already took all of the trabecular meshwork, which is where you're gonna plug the injectable, the device that is gonna have an extended release?
It's high value real estate.
You're gonna put it. Well, I just had to do the competition on a patient. It was a 3-stent device that already had a whole goniotomy. I had to put one of the stents temporarily, and that was a challenge. So it is important as we think of the next step to have that real estate safe.
When the residents ask me why I'm doing this, I'm like, well, I'm doing this here because in 10 years we'll need to do this here, and then there'll be room for this over here in 15 years.
Just brings home the point.
I
had a partner who would tell his patients, when you have glaucoma, you're living life on the installment plan, right? We're always kicking the can down the road. So our patients are living longer, right? It's not uncommon to have patients come in their 90s.
I live in Utah where nobody drinks and nobody smokes.
They live forever.
And I tell my 90-year-olds they need to pick up a vice. I'm like, can you maybe start pack a day? They're gonna keep going to 110.
Right, and it's a chronic incurable disease. So try to do something safe and non-invasive as a first step so you can save it. You have a question?
Yes. So I've actually repeated. So remember that this started in April. We've had the canaloplasty from before, but I've actually had patients that had a different kind of canaloplasty goniotomy in the past. And actually, even with a 90-degree goniotomy, I've gone back in and recanalized because you never go 360. So I've done repeat canaloplasties, not with this device, but with previous canaloplasty, with other devices, or goniotomies, with other devices, and I've gone back and recanalized the rest of the canal and dilated.
I think now's probably a good time. I mean, these are some of the questions that they designed for us, but we want to hear from you guys too. What questions do you have for us? Let's make this a discussion.
Yes. So I'm going to repeat the question so everybody can hear it. After you do the device, when do you see the effect? So I'm going to break it in two. I take the drops off. Every drop the patient is on, I take it off the day the patient gets the procedure. So if they're in 3 meds or in 4 meds, I just take everything off that day. They go into whatever steroid, antibiotic combo they're gonna get. And you see the response right away. I don't see spikes. Some people are afraid because of the amount of viscoelastic. Do you keep them on IOP drops the next day?
I usually keep them on something until I see them at a week, and then I have them stop at a week.
Oh, I take them completely. But I do check IOP at least with an iCare device the next day.
Yeah,
and
that's absolutely. I don't see them the next day, so that's why I keep them until a week.
I see them the next day, and I do check iCare pressures, and they're all without. Now, as they go through, I tell them they become virgins again. So we're gonna see this new patient, and I'm gonna treat you as a new patient. So sometimes, if a patient is on 4 drops, it's not a miracle. Sometimes at 3-4 weeks, I may put them on 1, but most of the patients end up with a lot less drops. And I would say it's the outlier that I'm back on lots of meds. Yeah, okay. And you see the response right away. And the second question is, how long do you see response? And there's data for 5 years with the previous handheld device. And with most of the mix, you're seeing 2-3 years at least.
Yeah. And that, I will say, that's 2 or 3 years less that a patient's having to live with possibly a trabeculectomy or a tube or some kind of larger intervention that, if you could give me 3 years less without a trab, I would take that.
I'm going to quote,
every single day and twice.
I'm going to quote the great George Tanaka. If you're in the desert and somebody gives you a ride in a camel, would you not take it? So if I can get a couple of years of 24/7 control without fluctuation in IOP, without progressing, well, it's 3 years less, and you can repeat it. and it still needs more time. I mean, this is all relatively.
And I also have to say, in the spirit of glaucoma doctors always preparing for the next surgery, the fact that not only am I getting them 2, 3, 4, 5 years before we have to move on to the next, that's possibly 5 years of less drop burden. And we know that whatever next surgery is coming their way, that conj is going to be healthier and your surgery is going to be more successful if you're doing it in an eye that's had less drop burden over time.
And the other way to phrase the camel question is, if somebody gave you a pair of Crocs that you could wear on the convention floor instead of heels, how long would you wear them?
Oh, I am so sorry, but see, but we're fashion girls, it's like, if I can wear those or the ones that they have that can change the heels. I've seen some fabulous shoes today. I think it's important to give less BAK. We have some doctors that live abroad and that are not in the US. Outside of the US, preservatives are the devil. And we're stuck with preservatives because of cost here. But we know that BCK damages the endothelial cells. We know that it decreases the mitochondrial activity. We know that we're making the disease worse. So we know that we're causing damage to the patient with our medicines. And we give lots of jobs to other surgeons because we make dry eye, we get ptosis, we get all of this other stuff to these patients. So I do think that if we can ride the camel for a little bit, I'll take it. And I think it's a long time we need. Thank you guys for having us. I think it's been a great talk. I invite you all to upkeep. We do have to do better, and it has to come from us. It cannot just come from industry or regulatory systems. We need to strive to do better. So thank you guys.
All right.